All right. Hello, everybody. Welcome to today's presentation. Dr. Ahmed is joining us. He's a graduate from NYCPM. He'll be telling us a little bit about himself and what he has accomplished so far. Welcome, Dr. Ahmed.
Thank you for inviting me. I appreciate the opportunity to be able to talk to the younger generation, educate them on what is it that we do, especially after we go out and practice, and what is it that we can do. I think it's a great way to at least let the people who are interested in the field know what it is that they can expect to do, what they can learn, and give them a little bit of a taste of what they can do if they go out and practice. I specialize in pediatrics. It is kind of near and dear to me because this was a field I kind of did want to go into, and when I had the opportunity to take a extra step in learning this, it really I was really excited and got the chance to spend specifically an extra year just to treat children. A lot of the injuries or deformities or any basic in-office things that you can treat as well for children. It's a completely different world. So I'm glad I took the time to actually learn this. So you can go to the next slide. So again, my name. Again, my name is Dr. Aamir Ahmed. I completed my bachelor's and master's in biomedical engineering from New Jersey Institute of Technology. I was born and raised in New Jersey. I was actually born in Hackensack, raised all my life in New Jersey. And again, my high school was at Teaneck High School. Then I went to NJIT for my engineering degrees. And then I went to New York College of Podiatric Medicine right after that. So why did I choose to go into podiatry? Well, when we learn engineering, if anyone from the crowd has gone into biomedical engineering, we learn a lot of mechanics of the lower extremities. So what happens is we all, from physics, we learn ground reaction forces. A lot of that put together was really enticing to me, and that's why I also did a master's. But while doing my master's, I also learned about podiatry, and I said, when I do engineering, a lot of it's, especially when doing masters and you go through a lot of your capstone programs where you're actually putting together certain devices, a lot of it's theory in engineering, and you're trying to put together these paperwork to come up with theoretical ways of doing things. But when I found the field of podiatry, I knew that when we deal with the foot and ankle and how and the ground reaction forces and having people walk, this is actuality. So when you go into the field and you're actually putting it into play and seeing the results right away, that was a bigger step for me. And I said that this is the field that I do want to get into, because when it comes to the field of podiatry is all aspects of foot and ankle and any foot and ankle pathology that comes in. So again, what my goal was, okay, if I want to learn how to treat someone and get them walking again, that would be walking pain-free. That's the best thing. Walking pain-free, that would be a very satisfying thing to me, because simply just walking is the biggest part of anyone's life. And we walk every day. But imagine when someone has a pain in a specific area and you can get rid of that and they go back to their normal lives, it's very to me, when I thought about that, I said, it was very satisfying. So I said, from my engineering degree, I'm going to go into podiatry because that's something that I want to do, because I thought it was going to be something that's very enticing and I can learn so much from it. So again, I went to New York College of Podiatric Medicine, and I graduated in class of 2016. Then I went for residency at St. Mary's General Hospital in Passaic, New Jersey. It's a three-year residency. We learned, it was, I would say it's majority actually adult oriented or adult patients. And you'll see a lot of residencies are like that, because again, when it comes to your residence at a hospital, so when it comes to treating a lot of patients at the hospital, you should typically see adults. You don't go significant on pediatrics unless you're in specifically a pediatric residency. But when it comes to podiatric residency, you'll see a majority adults. So again, it was a 3-year residency where I learned all aspects of adult foot and ankle fractures, diabetic limb salvage, wounds, wound care, as well as trauma, joint replacements, ankle replacements, all of that. So after residency, well, during residency is when I learned about the fellowship. Actually, it's in New Jersey. It's at the Pediatric Orthopedic Center. It's under the organization of the American College of Foot and Ankle Surgeons. And it's a 1-year fellowship. And when I got the chance to learn about it, and I met the director of the fellowship, the fellowship is out of a pediatric orthopedic group. So you get to work with the director, who the director is a podiatrist. He is part of that pediatric orthopedic group, and he deals with all their foot and ankle, majority of their foot and ankle related conditions in children. So I found out that I get the chance to work with him and a lot of children that he sees, as well as a lot of the conditions in the lower extremities with the other pediatric orthopedists too. So I got very excited about this, and I didn't hesitate to apply. And luckily, with my background and a lot of the things that I got to learn from my residency, I was chosen to be as a good candidate, and I was chosen for that fellowship. And I was very happy with that, because now, besides adults, I knew that I would be able to treat all ages now, from newborns all the way to the geriatric population. That's what I'm going to learn. So I completed my fellowship the next year, and then I started private practice. Currently, I'm in private practice. I joined another doctor in practice. We practice in Milburn and Westfield, New Jersey. And as soon as I joined, I do go to a hospital to do a lot of my cases. I do consults at hospitals. The main hospital I go to is Cooperman Barnabas Medical Center in Livingston, New Jersey. And there's a residency program there. There's a podiatric residency program there. When I got involved with that, I very quickly found out how I can get really involved, because I do like the academia portion. I do love teaching the younger generation. So when I got the chance to teach other residents what I learned, I got very heavily involved, and I became the academic director of that residency program. So you have typical residency programs. You have the director himself, then you have other positions for other staff. I became the academic director. Again, I like the literature, I like teaching, so it was something that I really pushed to get into. And I'm glad I did, because there's a lot that you can teach and you can embark, and the only way to really solidify what you learn is to actually teach. So I think it was a good move on my part. This way, I can always keep up with my knowledge and pass that on to the future generation. So what I'm going to do today is, number one, I'm going to speak about the pediatric population and why spend that. Number one, why spend that extra year? From what I learned, and you can see this in a lot of your allopathic colleagues, the pediatric is a very separate field. You can't take what you learn for adults and just extrapolate that and say, all right, it can do this in children too. It's not the same. For children, they're growing bodies. They change. When you look at x-rays from the newborn all the way to the time their growth plates close, which in females can be about 12 to 13 years old, which in males, in the male population, 14 to 16 years old. The x-rays that you see, they change every year. And I can tell you that if you don't have experience looking at x-rays, when you get out in practice and you haven't seen a lot of pediatric foot and ankle x-rays, you're going to have a hard time identifying, if there are problems, or if there's a certain problem on the x-ray. Sometimes you'll have what's called normal variants, which may appear as sometimes, and this happens in the emergency rooms or urgent care centers, where they'll diagnose someone with a fracture, a kid, but it's not really a fracture. Sometimes it's something called a sesamoid bone. So again, only experience with seeing these imaging x-rays and again, treating children on the regular, or actually getting the training to treat this kind of population, is the only way you'll be able to identify what's wrong and what's really not wrong, and what you need to actually intervene and treat, and what you don't really need to intervene and treat on. So That's why I spent that extra year. Once the growth plate's closed and, it's an adult, what's called skeletally mature, where after the growth plate closes type of x-ray, then sometimes you'll be able to tell the difference between abnormal versus normal. When it comes to kids, it's a little different. That's why I wanted to spend the extra year and to really learn that. And again, if you look at your allopathic colleagues, in orthopedics, after orthopedic residency, there's a pediatric orthopedic fellowship. And then when it comes to even general surgery, there's pediatric general surgery. Pediatric is just pediatrics in terms of medicine. So, you have a pediatrician. So it's a very separate thing. And you want to spend, if you can, either you spend the extra time in a very concentrated, fellowship, or you actually spend a while, even after residency, learning how to treat them before you start, really significantly treating, especially if you're going to do surgery on this population. So what I'm going to do is I'm going to just go through a few cases, some of the ones that I've treated recently, these fractures and deformity, and show you the type of things that you can potentially see and actually treat when you get out and you learn how to treat it properly. Let's go to the next slide. So this is a case of a 11-year-old female. She was crossing the street and she was hit by someone driving a car. It was actually a drunk driver. Kind of it was more like hit her, like more like a near miss. So she kind of twisted and fell and sustained this ankle injury. I'm not sure, I don't think you can see my mouse, but if you look at the picture all the way on the left, the x-ray, there is a fracture towards the inside or towards the right of that picture. There's a fracture, what's called the medial malleolus. And this is something that once you get the experience of seeing x-rays, then you can actually see that this is an obvious fracture. If you look at the ankle joint, so typically you have the three bones. You have the tibia, the fibula, the smaller, thinner bone, and then you have the talus, which is inside the ankle joint. Right above that joint, there's a separate line, which is the growth plate. And you commonly see this in multiple bones when the kids are in their growth years. So what happens is that the growth plate is a very significant area. You don't really want to mess with it if you don't need to, especially while you're treating kids with these fractures around the growth plate. So you have to, there are specific ways of being able to fix the fracture, but not messing with the growth plate as well. So in this case, again, if you look at the picture on the left, you can see the fracture towards the right of the picture on that medial malleolus. And what I had to do was basically reduce this fracture, put it back into place. And the most important part of this fracture is the part that goes into the joint. The most important part of anyone's typical daily life when you move around and you function is a healthy joint. So if someone has a fracture through a joint, you want to make sure that you put that joint back together. Otherwise, you can develop arthritis very early. Especially in children, you want to make sure that joint is back together. So again, when we talk about the joint, I talk about the articular or the cartilage surface. So this fracture was fairly mildly displaced. It needed reduction because of the fracture that goes through the joint. And what I had to do was basically reduce the fracture, hold it down, clamp it down, and put a screw across that fracture site. And as you can see, the way I put the screw in was parallel to that growth plate. Agatha, I'm not sure if you're able to point to the growth plate. So in that middle picture, if you go in the middle picture, so if you go a little higher than that, there's a line, a little lower. Yeah, right there. So if you go across, that's the growth plate right there. You can see that that's the tibia bone and that's the growth plate. So I needed to make sure that when I put this screw in, it didn't go anywhere near or through the growth plate. Because number one, I need to make sure that when I insert the screw, it holds the fracture very firmly, what's called rigid fixation. So this way, when I move the ankle, that fracture fragment doesn't move. So I had to make sure I avoid that growth plate at all costs. And I did. I inserted the screw in. This was rigid fixation. Typically after this, about 2 to 3 weeks, we get the patient move their ankle. They're walking in about 6 weeks. If you look at the picture all the way to the right, that's about a year after the surgery. Usually these kinds of screws that we put right above a joint, we try to remove them because they do put a little added pressure on the joint itself when when the kids are moving around. So it's recommended in children that we remove it. So it was removed, and the fracture and that joint is back together. It's perfectly in a normal position. So again, this is one detail, one type of fracture in the multitude of type of fractures that you can see. So again, when we talk about the joint, I talk about the articular or the cartilage surface. So this fracture was fairly mildly displaced. It needed reduction because of the fracture that goes through the joint. And what I had to do was basically reduce the fracture, hold it down, clamp it down, and put a screw across that fracture site. And as you can see, the way I put the screw in was parallel to that growth plate. Agatha, I'm not sure if you're able to point to the growth plate. So in that middle picture, if you go in the middle picture, so if you go a little higher than that, there's a line, a little lower. Yeah, right there. So if you go across, that's the growth plate right there. You can see that that's the tibia bone and that's the growth plate. So I needed to make sure that when I put this screw in, it didn't go anywhere near or through the growth plate. Because number one, I need to make sure that when I insert the screw, it holds the fracture very firmly, what's called rigid fixation. So this way, when I move the ankle, that fracture fragment doesn't move. So I had to make sure I avoided that growth plate at all costs. And I did. I inserted the screw in. This was rigid fixation. Typically after this, about 2 to 3 weeks, we get the patient move their ankle. They're walking in about 6 weeks. If you look at the picture all the way to the right, that's about a year after the surgery. Usually these kinds of screws that we put right above a joint, we try to remove them because they do put a little added pressure on the joint itself when when the kids are moving around. So it's recommended in children that we remove it. So it was removed, and the fracture and that joint is back together. It's perfectly in a normal position. So again, this is one detail, one type of fracture in the multitude of type of fractures that you can see. Did the presentation stop? Hello? Agatha? I'm sorry, let me see if I can pull the presentation up. I'm not sure if the students can hear me. I'm going to share my screen, see if you guys can see my screen. Okay. 1 minute. One minute, guys. Sorry for the technical difficulty. Let me just see if I can get the screen back up. Okay, it shows that I'm screen sharing. Okay, so if I'm sharing my screen, I will put this in presentation mode so we can continue. Here's the present. I get that if you can see my screen sharing. Oh, Samantha, are you there? Samantha, can you hear me?
Hi, sorry. I can hear you.
Okay, good. Do you see my screen sharing?
I do. Perfect. I'm glad that you're able to share your screen.
Okay, yeah. Somehow I got I guess I got the host capabilities now.
Amazing. That's exactly what I was here to check. Glad it worked out. Sorry.
Okay, perfect. Yeah, I think Agatha is having a little issue. Okay, so I'll continue.
Yeah. You can continue
all right.
and you can end it when you're done. Whatever you need to do.
You can see my mouse moving around?
I can. Yep.
Okay, perfect. So I can point to stuff now too. Okay, good.
Yep.
All right, so that's one case. This case, again, patient's fully healed, the fracture is healed, and this is the ankle joint. Now you can see I can move my mouse around. This is the ankle joint right here. This is all intact and in place. This is what you want to look for. Okay, and I'm going to explain another case. This is a more simpler fracture. I'm going to show you a more complicated fracture. So this is a fracture of an 11-year-old male. He fell off a motorbike. He was on a motorbike with his granddad, and he pretty much fell off, twisted his ankle, and he got a pretty significant injury. So in this case, not only do you have a fracture of the fibula, which is right here, and you have a fracture right here and displaced fragment, but you also have a fracture of the medial malleolus here. But there is another component of this injury, which I didn't put this because, again, not a lot of people have experience. I would expect people to have experience with viewing CT imaging, but there's a fracture actually right here, right in the middle between the fibula and the tibia, which actually broke off little pieces. So that typically means that the stability, or there's typically a ligament that connects the fibula and the tibia right in the middle here, and it goes all the way up like this. The fact that you have fractures down here means that the ligament tore off between the two bones. So you actually have to stabilize between the two bones, especially if you want to get the patient walking quicker. So if you look in the right, this is how we have to fixate it. You have this large plate holding the fracture of the fibula together, but you also see this line going all the way across. This is called a tightrope. And this actually stabilizes the two bones together. So it covers for that ligament. So you can have the patient to start moving and walking before that ligament is completely healed. So that's like your stabilizing segment. There's also another fracture that happened actually behind the tibia in the back. And I had to throw a screw from the back all the way to the front to actually hold that fracture and fixate it down. And then the fracture over here in the medial malleolus, it wasn't significantly displaced, and the articular surface or the inside of the ankle joint was actually pretty well lined up. So all I had to do in this case, I had to use smooth wires just to hold the fracture down. Now, again, typically the goal is to avoid the growth plate going near or through. But if you really need to stabilize a fracture, really need to stabilize it because there's no other option, then you can take smooth wires and go across the growth plate to stabilize it. So in this case, I had to take 2 smooth wires to stabilize that segment on the inside, and I was able to cross the growth plate. So when it comes to when can you possibly affect a growth plate with hardware, majority of the time, if it's smooth wires, it doesn't really affect it. If you're using threaded, something that has threads, like screws or wires, if you do that, then you can significantly affect the growth plate. So using smooth wires is a good option. Now, there are scenarios where even smooth wires don't allow good stability of a fracture fragment, and sometimes potentially you are sacrificing the growth plate just so the patient can have a good joint. And if that growth plate causes significant problems later on in growth, then you have to come back later on and fix it. But in this case, I did not have to really affect the growth plate. Therefore, I just put wires across it. So this is how I need to fixate this fracture. Now, you can also have fractures in the foot as well. A fracture in the foot, for example, in this 9-year-old female, she was driving a scooter and she was swinging her foot off the side, and suddenly she hit front end on from her toes to a sidewalk. And it caused, if you look at the foot, there are multitude of bones in the foot. Each of these little bones also, you can see that they have growth plates. They're all growing bones. In this case, the patient had a fracture in the 3rd metatarsal. You see right here, completely angulated. In the 4th metatarsal also, this is supposed to be right here. And as far as this 5th ray, we call it, there was no fracture, but the joint, the pinky toe joint, had dislocated. So this is something you have to put back together because it's very displaced. This is not something you can just leave alone. So again, when you're trying to fixate something, you try to avoid the growth plate. When it comes to metatarsal fractures, especially in children, you really can't avoid it to put a fixation. And you're trying, if you can, the best you can, trying to put some sort of very stable fixation without having to put so much hardware in children that it lasts, especially in growing bones, that it has to stay in with them permanently. Remember, these are growing bodies. We try not to put so much hardware when we're trying to fix something, especially in children, because they have so many years ahead of them. So we try to give them what they have naturally back together. So the goal here was to reduce the fractures, pin it in place in a very straight position. And basically these come out after about a few weeks. And the patient gets walking usually about 5 to 6 weeks in a boot. So this is how this injury was fixated. Now, these are fractures. There are many other, types of things that are treated. Simple in office for children. For example, a lot of athletes come in with ingrown nails. A lot of swimmers come in, swimmers or even, athletes who, walk barefoot in locker rooms and such. They come in with warts. So warts are a pretty significant issue in children. But they come in and this is something you have to treat. These are all in office. Kids are brought in by their parents because they're walking a little abnormally. So you have to figure out what's abnormal and what's normal, figure out how to have them walking quicker. Sometimes when they're very young, they look like they're walking abnormally. It just means that they're still, for example, in the first couple of years of life, they're still twisting out and they don't have a normal walking cycle yet. So you have to really figure out, hey, is it affecting them or is there something that I have to intervene? It doesn't have to be intervening surgically. It can be intervening with casting or orthotics. You give them inserts and you correct the way they walk. That can significantly improve in how they function in their normal life, when they're running, when they're walking. For example, I think the most common thing that you'll probably see is the mother bringing in their child because they have flat feet. The kid will say, I have no problems, I have no pain. The mother will say, wait, but you have flat feet, that's a problem. It's not always a problem. Flat feet is not always a problem. You can have flat feet and do a lot of things in your life. They don't always have to be corrected. You don't always need orthotics for that. You really need it if it's a problem, if it's causing pain. You can have local foot pain, arch pain. You can have leg pain because your certain muscles can be putting a little more excessive overtime work just to get you to somewhat walk normally. So that's where inserts or orthotics come in to fix the way the foot is positioned as it comes and hits the floor. So when you have these inserts really pushing up on your arch and fixing the way you walk, that itself you improve the biomechanics. That itself can help kids run longer because they don't have to deal with their arches dropping and then having to pick up so much. So again, these are simple in-office things. But let's just say a flat foot goes on and it has pain. Now you're dealing with a deformity that you may have to correct. So this is where the next case comes in. So here's a deformity case where I have a 10-year-old male. This is actually a case I did in fellowship. History of Klinefelter syndrome. You'll learn what that is. Well, Klinefelter is basically when a male patient has an extra X chromosome. And sometimes with these patients, you can have what's called ligamentous laxity. This patient was treated with conservative care for 3 years. They had orthotics to the point where they had not just orthotics, but they have additional what's called AFO brace. So it's a brace that starts in the foot and then goes all the way up to the mid leg and tries to hold your foot in a good position. This has all been done, but the problem is that this patient's flat foot was so severely flat that they had a bony prominence. When your joint or your foot goes in one direction, or severely in one direction, bones in the other, there are certain bones that stay in its place, but then they really push out onto the skin. And that causes a bony prominence, we call it. And those bony prominence, if they hit the floor, that can cause pain. So in this patient, you can see, this is from the frontal view, and as far as top-down view on the right side, they had a pretty, you can see how widened, or how it was called abducted, the forefoot was. It's pretty much sticking all the way out to the sides, to the outside. And if you look at towards the inside of the foot, you'll see these bony prominence. This area actually hits the floor and causes significant amount of pain to the kids, right down here. So even in AFO braces and orthotics, when they hit the floor, these bony prominence can cause significant pain. So typically after you undergo a decent amount of conservative care, you have to consider how you're going to treat the patients. So this involves a good physical exam. Now, this is not trauma surgery. It's not something that you have to suddenly go in and fix. This is something you're working up, making sure that you're identifying the exact areas that you have to treat. And knowing the anatomy around the area very well, you'll be able to know what bone you have to treat. You'll be able to know what tissues you have to treat along with it. You have to remember that in the foot and ankle, which is specifically in our the area of our field, there's a lot of tendons that run from the leg all the way down to the foot, and separate muscles and tendons in the foot themselves. A lot of ligaments, because there's so many bones that you're dealing with, so many bones. Again, each foot, right, 26 bones. So you're talking about each bone to bone, you're talking about ligaments, you know, how you have to, how you can cut through them and how you can repair them. So when you're doing a deformity correction, when you're performing a deformity correction, you have to sometimes release the ligaments on one side to make it nice and loose so you can do the correction. So these are all things you have to understand. That involves looking at the patients beforehand and really examining their foot clinically, meaning in person, seeing them stand, seeing them walk. When they're sitting down, looking at what joints are mobile, right? So if you look at this patient from the back, you can see how severely it was called abducted and pronated that both their feet are. Besides clinical, you have to look at the radiographic. There are certain ways of taking x-rays to really look at how the bony relationships are. So when it comes to foot and ankle x-rays, they always have to be what's called weight bearing, meaning when the patient steps down, that's showing you the true way the foot is looking and what's causing the problem. So in this case, you can see that this picture on the right is called a lateral view. You're looking at it from the side. The patient has a completely flattened arch. There's no arch here. And when it comes to the top-down view, or called the AP view, you can see the bones that was likely causing the pain on the inside of the foot was here. This is the talus and this is the navicular. Usually these come down and potentially hit the floor, or even the side of a shoe or the side of orthotic, or when they walk in a severely pronated position, again, it's hitting the floor and it's causing a lot of pain. The pain is really from the skin getting that reaction in that area and getting all the pressure. So you're looking at the x-rays beforehand, you're looking at what deformity and how the deformity is that you're dealing with. And after you look at the preoperative x-rays, these are some additional x-rays. Again, what we look at is bony relationships. So when you're correcting the foot and ankle area, you're looking at how is my rear foot or my heel in relation to my leg. And then you're looking at, all right, how is my forefoot in relation to my heel? Which bones can I treat to fix that? So those are the bony relationships you learn to look at. In children, in growing bodies, we also do full limb length x-rays, because sometimes these deformities can happen or they can occur due to possible issues with bones above the foot and ankle. You can have bowing in the leg bone, in the tibia bone. You can have bowing in the femur. You can have angular deformities in the knee that lead to increased pressures in the foot and eventually lead to potential flat foot. These happen in growing patients. So in this case, this patient, they actually had a completely normal alignment of the thigh and the leg bones. And one of the things we do is we measure that by measuring out what's called the mechanical axis. This is more advanced, this is more significant, and you learn this when you go to actually limb deformity courses. So during residency, fellowship, or even when you get out in practice, there are separate courses that you can take that show you how to really evaluate the patient's limb and look at any deformities. So these are some things you have to look at and measure out just to make sure there's no other problems going on above the foot and ankle that led to the problem in the foot and ankle. So preoperatively, what is it that you're looking at to improve? There are, again, bony relationships are the main thing you look at. So these bony relationships are the main things you look at before and after the surgery to see if you actually fix your deformity. For example, in the lateral view, you have the bony relationship between what's called the talus and the first metatarsal over here. Again, these are things you'll learn, especially when you look at the calcaneal bone, right? This is the heel bone right back here. If it's severely dropped, the angle is much lower. And again, these are things you'll learn where you'll learn what's normal, what's not normal, and what you need to do to get it to get it to the normal level. So we look at bony relationships in the foot area, but also the bony relationship between the foot, the heel bone, and the leg bone, the angular degrees, and as well as the ankle joint itself. After that, again, so before you actually do the surgery, not only are you looking at the bony relationships, but you also start thinking, all right, well, if it's not the bones, it's also the soft tissues. Just imagine that this patient's been in this position for a very long time. What does that mean? That the tissues on the outside of the foot can be very tight. If they're very tight, you're going to have a problem doing the correction. What is that? What about the tissues on the inside of the foot? The convex portion, right? So you have the concave and you have the convex portion of the foot. The convex portion of this foot, you're going to have tissues that are very lengthened. They're going to be longer because they've been loosened over time. So what do you have to do? You may have to tighten those ligaments. So you may have to release or lengthen some of the tissues on the concave portion of the foot, and the convex portion of the foot. You may have to actually tighten some of these tissues. That's the way you got to look. You got to know. You'll start learning when you do these corrections, especially during school. You'll learn which ones you have to tighten, which ones you can loosen. So when you do the correction, you're trying to get your correction to what's called within normal limits or to the normal level. So in this case, we had to make a cut into the calcaneus bone, because if you look at preoperatively, the calcaneus bone here, we sometimes it's probably a shorter calcaneal bone, or the lateral column. This lateral column out here, it's shorter than the medial column. The medial column is longer, while the lateral column is shorter. So what we do is we make a cut right here into the heel bone and increase the length of the lateral column, and we put an implant there that incorporates with the bone. So this increases the length of the lateral column. And then there are other ancillary procedures you have to do. It's really something that you'll learn, that you get to learn over time. But it comes naturally once you start doing it. But you'll start learning that there's a multitude of procedures. We had to lengthen a tendon on the outside over here. We had to lengthen some tissue, some fascia on the outside to help release our forefoot. We had to tighten up a tendon on the inside here. And we also had to perform an osteotomy through this bone, because you'll learn that when you're fixing a flat foot that's been so flat for a long time, the forefoot becomes something called supinated. So if you can fix the heel bone and put it into a good position, but that forefoot right here, it'll actually be a little more in a displaced position, and you have to actually correct that by taking this column right here and pushing it down. Again, these are details. What you're basically trying to do at the end here is you're trying to create almost like a tripod, where you have the heel and the first metatarsal and the fifth metatarsal, or all your metatarsals coming in down, and you create an arch. So this is only 2 weeks after surgery. This is not the true way to test to see if you got your correction. You let the bones heal, and then you do a good, what's called a weight-bearing view. This is 10 weeks after surgery, and you can see that the patient actually has a pretty decent arch now, and their foot and their overall foot alignment is corrected. And one of the best ways to see is when they actually step down and you're looking at the patient clinically. So here, again, this is only the right foot that we worked on right now. If you compare the right side and look at the right side now, you don't see much of a bony prominence anymore. So now the patient has an arch and can walk without a bony prominence, less pain. Okay, again, same thing from the back. This heel is significantly out of alignment along with the leg bone. It's in severe valgus. So when you compare post-operative views, the heel bone here is in very good alignment with the leg. And that's what you want to look for. You want to make sure that bony prominence is not severely, well, again, the rear foot is not pronated, and that bony prominence is not going to cause them a problem. So that heel and that leg bone is in really good position. So again, these are the things that you're looking at. I mean, you learn this as you go through the schooling process, and you learn how to correct these deformities. And when it comes to children, sometimes you'll have not only these, but you have some many other issues that you'll see that you'll be able to treat. When it comes to the pediatric world, I think one of the things I'll probably end off by saying is that again, like I said from the very beginning, it's a very different world. You're not talking always directly to the patient. When it comes to minors, unless they get up to about maybe 13 to even 18 years old, they probably understand very little bit. But younger than that, you're really speaking to the parents. The kids won't say much. They'll say, "Yeah, I'm good." They'll run around with, and they won't even know that they have an actual problem. Sometimes when it comes to pain, kids actually tolerate pain very well, a lot better than adults. After surgery, they are in much less pain very quickly. So you have to kind of protect them. Tell them, listen, you can't put weight on it. I know you feel good. You can't put any weight on it. You can't walk around. You really have to speak to the parents. Tell them you have to keep an eye on them. So again, when you're talking to the patient, you're really not talking to the patient. You're really talking to the parents and telling them what their kid needs and what you can do to improve how they walk and get them out of pain. So again, it's a very different world. When it comes to adults, you're speaking directly to them. Kids, you're not. It's really something that you're speaking to the parents, and you're trying to relay that a little bit to the children and help them understand. Because sometimes the kids will fight you off and say that, "Oh, I don't want this done." But sometimes, again, you're trying to convince them in a very simple way and explain to them that it may be something that they need. Even this happens to fractures too. Whether if it's something that's displaced, they're afraid to go to surgery. You really have to sit and take the time to explain to them what's going on and how you can improve, their future life. That's how they usually understand. So from my standpoint, it's a very different world. It's something that you really need to take the time to learn how to treat, because you treat it in a different manner than adults. So I hope you enjoyed the presentation. I guess at this point, maybe you can go on to some questions.
Sure, I had a question for you, Dr. Ahmed. So how fruitful is your career in terms of people kind of thanking you after the surgery of their kid and helping them fix the problems?
They're very grateful, because if they see their kid walking, running, especially a couple months after a surgery, they become very grateful. I mean, look, they'll send you letters and stuff like, "Hey, thank you." Especially if you have a high kid population and you treat younger athletes, they'll be very thankful because their kid can now go back into sports, or they can go back into their typical lives, and they'll send you pictures too, saying that, "Thank you, so much, and now I'm doing all the things that I love to do. My kid is a kid again. They're not injured, or they're not walking abnormally." So they will be very thankful for it. I will say that.
Okay. Somebody wrote a question saying that, is surgery a big part of the field, or is it something that you specialize in?
So no, when it comes to the field itself, even in foot and ankle, surgery, depending on what you do, it can be. So me and my partner do a lot of surgery, because we take a lot of call out of the hospital. If you were to just do work out of the office and you didn't take any call at a hospital, you chose to just make your schedule, your typical 9 to 5, your surgery load will be based on the patients that come in and the type of problems that they have, where you're treating them conservatively, and if conservative management fails, then you'd go on to potential surgery depending on the condition. When it comes to, if you take call at a hospital, what comes to a hospital? Typically injuries, especially for the foot and ankle, it's injuries or potentially sick patients like diabetics who come in with infections. So when we take a lot of call at a hospital, at actually Cooperman Barnabas Hospital, and we get a lot of infections that come in. So yes, you have to go in and for me, my practice, yes, we do a lot of surgery because again, with all that call, you're getting sick patients coming in with infections, healthy to sometimes sick patients coming with fractures. So you have to treat them properly. So we are doing a lot of surgery. So so from your standpoint, it doesn't have to be. There are podiatrists that choose not to do any surgery. They do everything that just comes to the office, and that's it. And then there are podiatrists that have a mix, and there are podiatrists that have a heavy amount of surgery and spend a lot of time doing the surgery, whereas less days in the office. So it really depends on you, how you want to make it. If you want to, and I'll be very honest, if you do take a lot of call, it is a lot of hours that even sometimes later at night that you are going in for surgeries. So if you don't want that lifestyle, you don't have to. If you want the simple outpatient type of surgery, you want your office work and you set your hours, you don't take any call. Whatever patients come into you, you treat who need to potentially go on for surgery, you schedule it at the times you want. So you can have a lot of office and some moderate surgery and some mild to moderate amount of surgery. So it kind of comes to what you want to make of it. I wouldn't say that it's something it's the field specifically, it's heavily surgery. It's not.
Got it. Thank you. And also, can you tell them what are the steps of becoming a podiatric surgeon? Like, how did you start?
So the steps, obviously completing your 4 years of schooling at the school of your choice. I would prefer New York College of Podiatric Medicine. It's a great school. You definitely get to learn a lot. And then after that, you have your three-year residency in podiatric medicine and surgery. Majority of the residencies, I would say over 96 or 98% of them, they're all certified for foot and rear foot and ankle surgery. So you should be able to learn all aspects of foot and ankle surgery. That's 3 years. A couple residencies here and there are 4 years. So depending on which residency you get into, you'll learn which ones are 3 or 4 years. And then after that, you can go on practice after. If you feel like you've done a good amount in your residency, you can go on and practice directly after residency, and you'll be basically you'll be able to start practicing, and you'll be able to start doing your surgeries right after residency. If you choose to do a fellowship and do something more specialized, then you spend a year in fellowship, and then you can go on and practice, and that's how pretty much you become podiatric medicine and surgery and a surgeon.
Okay. Can you tell us a little bit about how NYCPM helped you, and what are the skills that you still use and you would love everybody to have it, especially during your third year and fourth year, if you still remember? I'm pretty sure you remember them.
My third year and fourth year, I would probably say, probably more for my fourth year. It's really the clinical aspect that I'm, when you're undergoing your third and fourth year, you do a lot of clinics, and really from there on, because after school, when you undergo residency, depending on what residency you have, you can be doing more surgeries and less clinic versus more clinic and some surgeries. So I did a residency that was heavily involved in surgery, and it was some clinic. So really the clinical aspect and how to be efficient in the clinic, I kind of picked that up during my third and fourth years when I was seeing patients in the clinic. So that's probably something that I took into practice right now, and how to be efficient. What are the different things you can do in the clinic? But as far trust me, running your own practice, seeing patients, and seeing how to efficiently see patients, and seeing what you can do for them and improve their condition efficiently, that itself is a skill. Especially nowadays. If you listen to any of the previous lectures, if you heard about insurances, that's all of medicine right now, insurance problems. But being able to efficiently see patients in the office is probably something I would say I learned more from the third to fourth year in the clinical in school.
Okay, so you're talking about the Foot Clinic of New York that's attached to the school. Okay.
Mm-hmm. Yeah.
All right. So what is your life balance kind of a thing? Do you like to do a lot of surgery? That's a next question somebody asked. Do you like to do a lot of surgeries, or do you like to see patients in your clinic?
I like doing both. I wouldn't say I like doing a lot of surgery. Because to a certain point, so for me personally, I don't like just sitting in one office every single day from 9 to 5. In my standpoint, it can be, I don't like having the same thing every single day, right? It doesn't have to be same type of patients, but what you'll get to learn is that when you see like, almost 25, 30, 35 patients in a day, you're going room to room and you're diagnosing something and getting out. What I like is a mixture of clinic, I'll have that, or the office setting, and I like going for surgery because I like, and the reason I do that is because I actually like planning the surgical aspect and actually performing the surgery and actually seeing those results. That's the whole reason for me personally, why I did this, because again, when it comes back to what I learned about biomechanics, actually seeing that in effect comes with surgery. So if a patient has a deformity and you correct that deformity and they heal and they're properly walking now, I like to see that. So I do a decent amount of surgery. Obviously from my life, I do take a lot of call. My partner and I do take a lot of call. So we do a lot of surgery. But I wouldn't say it makes up the biggest portion because at least 3 to 4 days a week, we are doing the office setting. And you'll learn that you will need to do the office, in an outpatient setting, especially when you get out in practice. You can't just do surgery and really thrive because again, the only way you get these cases is if you actually are in the office and seeing patients or if you're taking call. So I like a balance between both. I don't like doing the same clinic, one room after the next. All you're doing is just going and seeing patients and quickly trying to figure out and treating them. I like spending the time in the operating room, taking the time to actually fix someone's problem and fixing their foot, their deformity, a fracture, whatever it is, because that's something that I was interested in.
Perfect. Thank you so much for your questions. Any other questions, guys? Please type it in your Q&R and we could always answer them. If not now, I could always send you an email with the answer. And in terms of admissions, if you have any questions, please feel free to reach out to us. You could always do a virtual advisement with me, Samantha, any of the admission staff, and we could assist you all the way until getting enrolled. The deadline for enrolling for this fall semester is approaching soon. It will be June 30th, so please apply now. And I would basically tell you with everything that Dr. Ahmed had to say, the profession is really on demand. And can you tell us a little bit about the rise right now in your field and how many doctors do we have to compare to the amount of patients kind of after the pandemic and the rise of everything?
So as of right now, I mean, from my experience, yeah, during the pandemic, obviously everything pretty much went down. You're definitely going to have low patients, but believe it or not, during the pandemic, especially if you take call, the hospital wasn't really down, I would say. Obviously the hospitals were filled with COVID patients, but unfortunately, it did affect a lot of diabetics also. So we did unfortunately see a lot of diabetics in the hospitals, even with their foot infections, even during the pandemic. So at least for us who, we take call at the hospital, the workload didn't really go down in terms of the hospital. Yes, the workload does go down in the in-office setting because people were staying home. But after the pandemic, yes, everything kind of, kicked back up. Right as of right now, it is up to pretty much normal levels as far as seeing patients in the office and how many patients you can see. So it's gone up. You will have a pretty good workload. I probably see about 30 to 35 patients in a day. I try not to go more than that. I do spend time with my patients. So that's probably, again, when it comes to if you are going to plan to do surgery properly, you do have to spend the time to actually plan out surgeries, things like that. So I do like, I don't go too crazy on the amount of patients. So my workload, I would say, is definitely up there right now.
Perfect. If any of you have any questions, we have about.
I think there are some questions in the chat that probably didn't go to. I think someone asked, can you do both calls from the hospital and in-office mix, and do the calls mean a less predictable schedule? So in terms of both calls from the hospital and in-office mix, taking call at a hospital is different for the office. when you're part of a group in an office setting, yeah, you will rotate calls for the office. But that doesn't mean that it's something that leads to, sudden surgery or sudden hospital setting. It doesn't have to. Maybe a private patient of yours for the office got an infection and they're up in hospital. Then yes, then you may have to go to the hospital. Taking call for a hospital is different. It's a completely different scenario. It's you're going to be part of a medical staff at a hospital as part of as a consultant. But what you do is there's a podiatric department in that hospital, and in the department there's a department director, and then there are other department heads in that department. So what happens is they set up a call schedule. So if anything foot and ankle related, depending on the hospital you go to, if anything foot and ankle related comes through the emergency room, whoever's on that call schedule for the hospital is the one, are the people that are going to take call at the hospital. So that's different from your office. So can you do hospital and office? Yes. For example, I'm part of an office, so I rotate with my partner in terms of call for the office, and then I take call at the hospital too. So yeah, there are certain times. I mean, the office call is usually not as busy as the hospital. When you're on call at the hospital, you'll definitely be a little more busy at the hospital. So do the calls mean a less predictable schedule? Absolutely. Absolutely. Any profession that takes call at a hospital, right? You can be orthopedist, you can be a general surgeon, you could, again, any special hand or plastic surgeon. It is definitely, when you're on call, or whatever, the weeks or the couple of days, a few days or a week at a time, it is a less predictable schedule for that time that you are on call at the hospital. Because again, you don't know when something comes in. You could be middle of the night. So yes, when you're on call at a hospital setting, it is definitely less predictable. If you're just on call in the office, again, you don't really get as much urgent stuff to go into. So I wouldn't say it's less predictable for an office call. Let's see. So I think someone asked, in terms of residency, you can choose a more surgical one or a more clinical one depending on the program. Yes. So I wouldn't say choose. I would say that when you go through, when you're undergoing your externships, you'll start learning about different residencies from the previous years. And you obviously have to ask these questions, but you'll start learning that certain residencies have a lot more clinic, and they have, mild to moderate amount of surgeries. It's usually just enough to complete, your numbers for surgery. And then there are residencies that have way more surgeries and less clinic. So it depends on what you want to do. You'll still complete all your numbers, all the numbers that you need, and excess of that in terms of surgeries. But you'll learn that there are certain programs that have much more heavy. There's a very significant amount of surgeries because they're big hospitals. Bigger hospitals means larger amount of podiatrists that are on staff. And when you only have larger amount of podiatrists on staff, they come and do surgeries at the hospitals too. So you'll learn that. So you'll get to do scrubbing with a lot of the podiatrists in the area that come to the hospital and do surgery. So it can be a larger amount of surgery that you get to experience versus doing a clinic. So when it comes to choosing, again, when there's always a match program. You do externships at this program. You have to visit programs to really, and you have to wow, obviously the current residents and the director when you meet them. And then when you go to the match, if they rank you, and you, depending on how you rank the program that you want, then you'll match. So it's not about choosing, but yes, you can rank the programs that you like. If you like the more surgical ones, then you rank them higher, and you're hoping to get one of those higher surgical programs. So that's how it works. It is a match process. Can you plan the surgical? Another question: can you plan the surgical aspect even though there are calls from the hospital? Are you on call? Or I'm sorry, can you plan the surgical aspect?
I think you answered most of them.
Yeah. Okay.
I had a question for you.
Yeah.
So what do you think in terms of NYCPM? How did that offer you success in terms of placement rates and all the other resources that you have?
Oh, absolutely. So I would say as far as NYCPM, when it comes to their education, I will say they really hone down to make sure that you know your stuff. Let's just say that. So you're typically doing very good, at least from when I was there, you're doing very good on your boards from NYCPM. majority, I think 96, 98% do very well on the boards. And because of that, again, a lot of these boards, if you pass it right away, these are looked at when you're going to residency programs. So when it comes to the residency programs, when they see that you pass it right away, you don't need to take it over again, then it's more likely that that you'll get a spot and you'll be looked upon. And especially when it comes to the grading system and the way it works here, I will tell you that when it comes to a lot of the residencies in the tri-state area, they know that the grading system is a lot more strict here at New York College of Podiatric Medicine. So when they see that you do well, that elevates you and puts you definitely more at the top, because it is a tougher program. It is the New York College of Podiatric Medicine schooling is definitely a tougher program, where they really hone down to make sure you know what you need to do, and you are getting exams very frequently just to make sure that you are on top of what you are learning, and you learn everything, or at least you keep in mind everything that you learn. There's a lot. There's things that you're going to go through, and by fourth year you're going to forget a lot of stuff you learned first year. It happens. Again, first year, second year, a lot of that pre-clinicals, you will learn some surgical stuff during your second year, but third year and fourth year is when you'll learn the major stuff. So, but I will tell you that NYCPM is on top of you to make sure that you are doing well, from my experience, because they frequently quiz you here and there just to make sure you know your stuff. And I think that was really helpful, and from the schooling standpoint.
I think that helped a lot with you clearing that. And a lot of students tell me the same thing. And also, just to let everybody know, the placement rates here are great. They've always been 100% going back almost 100 years, no matter. And we are the first medical school in pediatric medical school in United States, established in 1911. So definitely we are 6 o'clock right now. We need to end the session. If you have any questions, feel free to reach out to us. The admission team is always here to help. And also you could have a virtual advisement to see if you're able to enroll, if you have all your credits, if everything is in check, whatever you need, please feel free to reach out to us. Thanks, everyone. Thanks so much, Dr. Ahmed. I learned a lot.
No problem.
And I hope everybody else learned too.
Yeah, absolutely. No problem. Anytime. All right. Have a good night, everyone. Take care.
Thanks.
Bye.